Hello, I'm Norman Swan. Welcome to this program on managing difficult consultations. We're going to be talking about those close encounters of the unsatisfactory kind. All health professionals have them, the consultations that upset you, frustrate you, anger, or maybe even frighten you, the patients that pull you right out of your comfort zone. We're going to look at what it is that makes consultations difficult and what strategies you can use to help you recognise and perhaps respond more effectively to what's going wrong, and perhaps even recognise more effectively what's going right. This programme is a joint initiative of the Rural Health Education Foundation and the New South Wales Department of Health. You'll find a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. Now let's meet our panel. Narelle Shadbolt is a general practitioner and a senior lecturer in the discipline of general practice at Sydney Medical School. Welcome, Narelle.
Thank you.
Narelle has a particular research interest in the health of doctors and students. Tim Usherwood is Professor and Head of the Department of General Practice at the University of Sydney and is based at Westmead Hospital. Welcome, Tim. Tim works as a GP at an Aboriginal medical service in Western Sydney and he's written a book about what happens between doctors and patients entitled Understanding the Consultation, Evidence Theory and Practice. Brendan McPhillips worked for a number of years as a general practitioner before undertaking training to practice as a psychotherapist. Welcome, Brendan.
Thanks, Norman.
And Brendan has also a long-standing interest in improvisational theatre, and as you'll see in a moment, we will test that to the full. Marianne Johnsey has been Medical Director of the Sydney Medically Supervised Injecting Centre since 2008. Welcome, Marianne.
Thank you.
You've dealt with a few difficult patients in your time.
One or two.
Marianne's a public health physician and has worked in the drug and alcohol field for over a decade. So welcome to you all. So Tim, is this what we call the heart sink patient?
I don't like that term. I think it labels the patient, the person, as a problem for all doctors. I think there are heart sink consultations and perhaps there are heart sink relationships, but the patient with whom my heart perhaps might sink, your heart might not, or vice versa. So I think that the heart sink patient is not just unhelpful because it doesn't address the problem of the difficulty, which is perhaps in the relationship or the interaction, and also I think it unfairly labels individuals.
Well, they're heart sink doctors then?
Well, look, I think the difficulty arises when you've got a mismatch between the patient's agenda, the doctor's agenda, and no, I don't think there are heart sink doctors the same as there aren't heart sink patients. It's something that's gone wrong in that interaction, if we can find out what that is.
So, Brendan, you agree you can't stereotype or typify the situation?
I absolutely agree with that. I think that, in fact, not only is it that the term itself is wrong, but I think actually it makes the consultation almost doomed to fail. Because what happens is that once either I have labelled someone as a heart sink patient or the patient has a particular attitude toward me because of my behaviour, then you've got a polarisation. And I think what happens then is that the consultation actually can very easily go pear-shaped.
How much of it is, though, the doctor not recognising what's going on, Marianne? You know, looking to themselves, not recognising their own reactions?
Look, I think that's part of it. And I think, you know, as doctors, we all need to acknowledge that we're human and we each find individual situations particularly challenging for us, given maybe what's happened that day, that week, or in our life generally. There's certainly particular situations that I think a lot of us would find challenging generally, and I think, as Narelle said, it's often when there's a mismatch between the expectation and what we're able or willing to give or provide.
What I want to emphasise tonight is that this is really a guide. There's, you know, there are right ways and wrong ways, but probably not that many. You know, it's going to be hard for us to set rules here. We're going to give a guidance. We're going to kind of show you what can go wrong and perhaps give you some tips to what may go right. Not necessarily that we hold all the answers. That's why we'd like your contributions as well. So rather than, you know, going on a little bit in this conversation, let's do it through case studies. And we've got some film case studies for you tonight. The first one is Philip. He's 27 years old. He's He's come to a new doctor seeking a script for OxyContin for recurrent pain. He's had kidney stones and he first suffered from stones about a couple of years ago. Let's have a look.
Take a seat.
Thank you.
Good morning, Philip.
Dr. Matthews, is that right?
That's right.
Nice to meet you.
Yeah. You're new to me, I think. Have you been here before?
No, I've actually just moved into the area. I used to live in Orange.
Oh, that's a nice area.
Yeah, lovely. Yeah, I was out there working at Charles Sturt University.
Oh, what were you doing?
I'm doing my doctorate in education.
Oh, wow.
Yeah, so I moved here to do some in-field research and get in contact with some new resources and stuff.
Okay.
Yeah.
That sounds great.
Yeah, it is. That's good, thanks.
Now, what can I do for you today?
Look, I've actually got an ongoing issue which has flared up again, so which is why I've come to see you. About 2 years ago, I got kidney stones.
Okay.
And so they flare up every now and again. The pain comes back.
Right, so, I mean, is it a dull pain or a sharp pain?
Really, really sharp pain. I mean, there's a more dull pain that kind of radiates around my kidneys, and that's sort of more long-term and dull. But when it flares up, the shooting severe pain down to my groin is just excruciating. And that's what happened last night. I was at home and I couldn't read, I couldn't work, I couldn't even think. I was just sort of doubled on the couch with a hot water bottle all night.
Yeah. And how often does that happen?
It flares up every couple of months. And so my doctor and I back in Orange have been monitoring and dealing with that pain using OxyContin. So, yeah.
Right. Okay, so that's your doctor, what was his name?
Dr. Roberts.
Roberts.
Yeah.
And his first name?
John.
Okay. John, I might give him a call.
Yeah, sure, no, do give him a call. He's actually overseas at the moment. Yeah, he's gone over to do some work with Johns Hopkins University.
Oh, Johns Hopkins, right.
Yeah. So when I called, there was no one there because he runs his own clinic. But look, give him a call, you might be able to get through.
Okay. So you said OxyContin, so that's what you've been taking, is it?
Yeah, that's what we've been using because it's over the couple of years we've found that's the drug that cuts through the pain but allows me to keep functioning.
Right, okay. Look, there are quite a lot of new medications on the market that can equally do that sort of job. And I think maybe it's time now to start looking at a change of medication after a couple of years, you know, sort of. The other thing is that at this point I'd like to revisit the whole situation and maybe get those tests run again.
Sure. Look, no, I'm happy to do the test. I'd really like to get on top of the whole problem. In the short term, though, I'd really like you to write me the script for OxyContin because while we look at other options and stuff, I just want to be able to keep functioning. And we know that the OxyContin will cut through that pain. So while we wait for those tests and work out what the other options are, it'd be great if you could write me that script for the short-term solution.
Right. Okay. Look, as I said, this OxyContin, well, it's just probably not the sort of thing you want to be taking over a long period of time.
Dr. Roberts didn't seem to think there was a problem. He sort of said that, you know, we've tried other things that haven't worked, and once the kidney pain is there with the kidney stones, the pain will keep coming back, and it's just a matter of dealing with the pain, and OxyContin is what's done that.
Well, what else did you try?
Look, we've tried endone in the past, and look, it's okay. It doesn't really do the job, though, that the OxyContin does, and I can't really function on the endone. I can't really work.
It really does knock you around, doesn't it?
Yeah.
Anything else?
Look, we tried Panadine Forte way back at the start and a couple of other things, but they never really did the job, whereas OxyContin we found allows me, as I said, to both be pain-free and also be functioning and being able to write my thesis.
Right, OK. So you're wanting a script today for something to deal with your pain, yes?
Absolutely, yes.
And I can do that.
Fantastic.
Yeah, but as I said, I'm not keen to write a script for OxyContin or endone. They're both quite specific drugs and they can cause problems if they're taken over a long period of time.
Sure, and as I said, in the long term I'm happy to look at other options, but right now I'd like you to write me the script for OxyContin because I've got a lot of work, I've got some deadlines coming up, and I just don't want to take a gamble not being able to work.
So, you just want me to write a script?
Today, yes, that's what I'm here for. I want the script so that you can help me deal with my pain. I don't know why you're resisting helping me deal with my pain.
I want to help you with your pain.
Good, then write the script for OxyContin.
It's not that simple.
It is that simple. I'm in pain, you know what fixes it, and I know what fixes it, and that is the OxyContin.
It's not how I run my practice. I don't just write a script. You know, I can't just do that.
Yes, you can. That's the point. You can help me fix this problem, but you won't.
And how many other people have you asked just to write a script?
What are you suggesting? I can't get in contact with my doctor. I'm in pain, so I've come to you for help, and you're resisting helping me. Write me the damn script, and then we don't have a problem.
All right, I'll write you a script, but don't come back. I never want to see you in this practice again.
Good, thank you.
High drama there, Marianne.
Look, it was. I was sitting here thinking, oh,
You'd have had one or two people asking you for OxyContin.
Yeah, I mean, it certainly helps being in a practice where there's a well-known policy, and certainly where I used to work, you know, it was well known that we weren't a practice, given that we saw a lot of drug and alcohol patients, that routinely did that. And I think that, you know, in that situation it would have helped, because there wouldn't perhaps have been the expectation.
So you can set expectations in your practice in general terms of policies, but we're not really here talking about the clinical situation of how to manage somebody who may or may not have real pain, may or may not require, you know, reasonably a medication. Just to analyse the consultation for us, because it clearly went pear-shaped.
Yeah, look, it did go pear-shaped, and I think probably both the patient and the GP would have agreed with that analysis. I guess I wasn't clear at the end of that consultation really whether the patient was somebody primarily that had opiate dependence, whether it was a patient that primarily had pain and was seeking you know, pain relief through OxyContin, or whether it was a combination of those things. I don't think that was well kind of elicited from the GP. And, you know, look, in the beginning I think she, you know, attempted to create some rapport, but it seemed to go pear-shaped in some ways relatively quickly as soon as she realised he wanted a script and she was uncomfortable about being directly and saying no, and at that point it kind of fell apart.
Brendan, what's your reading of the consultation?
I think the doctor got ambushed, that she started out with the thought that she had a patient in front of her who was suffering from renal colic and needed some pain relief. And I think at some point in the consultation, perhaps when she just kind of purses her lips and gets a bit jarred, I think she then realises that there's something else going on. But rather than being able to get out of it, she's been pushed more and more into a corner. And I think at the end of the consultation, she feels that she's got nowhere to go. And I also think that she probably feels a lot of shame around what's happened, that she missed it, that she got ambushed, and she capitulates.
And she feels there's nowhere to go.
There's nowhere to go.
Narelle?
No, I agree, and I think you can see that pivot point in the consultation, and you can, I mean, I think we've all had that sense of, uh-oh, we're about to lose control of the consultation, and she really did lose control of it, I think, and that's when doctors feel very uncomfortable.
Yeah, and I think what she tried to do then was just to impose her own plan.
Yes.
And then she'd lost him, and he just came back bullying and escalating to the point that she cracked and gave in.
Do you think, it's impossible to get inside another person's head, but do you think she was monitoring herself and understanding her own reactions, or she just got into it? She took a dislike to this guy and went for it.
It seemed to me like the agenda changed, that the agenda changes from about what the patient has come in for to an agenda which is about, I don't want to do this, and how am I going to...
And I'm feeling pushed around.
I'm feeling
and
pushed
I don't
around,
quite know how to
so it's no longer...
So we've got a comment from Irene Russell in Western Plain Medical Centre saying, I don't think any strategy works for these sort of patients. Tim?
Look, I think this is always a very, very difficult situation. It's the person who may have a history or ongoing painful pathology, but that they have become used to using a particular medication, which perhaps using it beyond the indication for pain relief may be starting to develop some dependence on it. It's very difficult to understand, particularly in a short consultation. You have to take the time to listen and to really understand why that patient is there, the context which they're bringing. And I think she didn't do that. She moved from what should have been, first perhaps appeared to her as a straightforward response to episodes of acute pain, to then relabeling the situation as one of perhaps drug-seeking behaviour. I'm making an assumption there, but it seemed to be, and then trying to impose a plan. She never seemed to me to take a step back, try to understand the whys of why this patient's there, the context in which they're undertaking this consultation.
Yeah.
Charles Herdy of the University of Queensland asks whether it's reasonable to ask the patient to leave when their temper seems out of control.
I think when that's happened, you've actually lost control anyway. And one of the things that struck me about the video, about the consultation, was that the patient started out in a very agitated way and was very directed. And the doctor, although she started out herself fairly calm, I think probably just expecting a normal consultation, she started to mirror the patient in terms of agitation, and that they were both, by the end of it, against the wall. I mean, I think if it starts...
Or clinging from it, as the case may be.
Fleeing, yes, that's right. I think that's right, Norman. And I think if it becomes dangerous, yes.
And that must be a worry, Marianne. You know, the fear in your mind is, could this not just go pear-shaped, but could I actually be exposed to danger?
Yeah, I mean, I would have to say, having, you know, worked in the drug and alcohol field for a while, you know, I've certainly seen more episodes of aggression in an everyday emergency department than I have where I've worked, and I think a lot of it is about working with patients and, you know, if you like, putting in a plug for kind of, you know, these patients. I mean, I have never had a situation where I've, you know, felt that, you know, the patient's really done wrong by the practice, or, I mean, certainly there's been situations where people have been out of control, but at the end of the day, I think most of us, you know, walk a day in their shoes and go through what they've gone through in their life, and it's very easy to say, oh, look, they're drug seeking and that's not my role. It's not my role to give them drugs, end of story. There is always an awful lot more going on, and I think when you can get to a point where you're working with somebody, and, you know, it might be that they're opiate dependent and we need to think about, you know, substitution therapy. It might be that there's chronic pain as well on top of that, or... But, you know, I think if you can really work to a point where you're working with someone, there's no reason that they can't, that they're any more difficult, less difficult, more agreeable, less agreeable than any other kind of patient.
Daryl D'Souza asks, how do you clearly define boundaries with a patient without hurting their feelings?
Well, look, I think it's good to be honest with the patient very close to the beginning of the consultation, when you realise that you're being asked to do something that you're clearly not wanting to do or you're not going to do. That's the time really to say that to the patient in some way, because I think what happened in that consultation was that it was a very long way down the track, too far to come back from the fact that she might be going to give this prescription.
So what would be your strategy here in an ideal world?
To have a practice policy. And in fact, the practice I work in, we have a policy, and it's one that we've talked through and agreed. And it then becomes possible to say, it's our practice policy. So in a sense, it removes it slightly from a personal, it's not me being nasty to you, it's a practice policy. That's the framework we're working in. Let's find another solution.
Another solution.
So let's look at another way that our GP could have dealt with this situation.
So look, I don't really need to take up too much of your time today. Dr. Roberts and I have been dealing with the pain using OxyContin, and so if I can get a script for that, then, I mean, I can go back and keep working my thesis and everything should be okay.
Yeah. Look, we obviously need to deal with the pain. We need to keep it under control, that's clear.
So you can write me a script then?
I can do that, yes. But I actually am wondering if there's something more than the pain. What I'm seeing is that you are very stressed and anxious.
Well, yeah, I'm in a lot of pain and I've got a lot of things on. I mean, that would make anyone stressed and anxious.
Absolutely, yeah, that's right. But I'm wanting to get more of a sense of your use of the OxyContin.
Right, well, I just use it to control the pain.
Yes, but you've been on it for 2 years now. I'm wondering if over that time you've noticed any change in your use of it. I mean, are you taking it more often? Maybe you're taking more of it?
Well, I mean, I guess there's been a slight increase in terms of how much I need to take to control the pain. So in that respect, if I can get a repeat prescription for me, that'd be fantastic, because it'd make sure that I've got a buffer there if I run out.
Before we get to that, though, I'm also wondering if at any time you felt the need to use it when you don't have pain.
Well, I mean, maybe a little bit, but it's when I expect the pain's going to start.
Right.
So I try and get there, you know, counter that before it happens.
Okay. So you've been on it for 2 years, and what I'm hearing is that you have noticed change, that you're taking it more often, maybe a bit more of it, and now, as you say, even sometimes when you don't need to take it, when there's no pain. So I'm wondering, do you get a bit anxious? I'm guessing that you get a bit anxious when you haven't got any on hand, just in case.
Well, yeah. I mean, I know from experience that the pain can flare up at any moment. If I don't have the Oxycontin there to control that, yeah, I get quite anxious about that.
Right. Is it causing other problems for you?
Well, I mean, yeah, being anxious is never fun.
I mean, with family and friends, work, things like that.
Sure, maybe a little bit.
You've noticed yourself that things have been changing over these last couple of years. I think we have a problem here that you're aware of yourself. You're taking more of it, more often, sometimes even when there isn't any pain. And I think, you know, that we need to think about trying to get you onto some other medication, perhaps. I think we need to work together to find a solution to what's going on. We need to take control.
Sure, look, I want to do something about this. I just don't know if this is really the right moment.
So, better consultation, Marion?
Look, there are certainly some things I think that she did much better that time, and that she tried to get a better picture of what his use was, whether it was kind of unsanctioned use and outside guidelines, whether I'm not still quite clear whether it was every day and multiple times a day, or you know, I'm interested that early on in the consultation she seemed to give him the indication that she would be writing the script, and you know, I would wonder in that scenario if he's seen that as the goalpost, that's perhaps why he's being a little bit certainly more polite than we saw him in the first consultation, and I think that, you know, that's something to talk about. And whether, I mean, certainly for me personally, the first time that I had seen someone, if I didn't have any more information, it was a new person to the practice and that was all I knew, I certainly wouldn't be writing a large script for Oxycontin.
Brendan, but just the elements now of the interaction, the consultation, and the way it was dealt with. Still not perfect. I mean, well, how can you be perfect in this situation? But I mean,
at that pivot point, which I think is a very good description for it, instead of pursing her lips and going back, she actually took a breath, which I think was to give herself space. And then, instead of becoming defensive, my sense of what was happening was that she actually moved toward him and she said, I can see you're in a lot of pain, which I think gave him the message that she was trying to understand where he was coming from. And she just paced it. And I was just having a thought as I was watching that she was almost modelling a particular rhythm. So rather than in the first video where they just go like that, she's actually helping him to slow down.
So she's hoping that he mirrors her rather than her mirroring him.
Yeah, which I think he does, because he actually was able to reflect that, yes, things haven't been great for the past 2 years. So I think there was something just about her manner, her pacing, and that she was trying to see it from, Marion, I think your phrase actually, to be in his shoes, was exactly it. That doesn't mean you capitulate, but it means you try and see what he's experiencing.
One of our questioners here from Griffith is asking, you know, why wouldn't you just bail and give him the script? What harm is there? Tim?
Well, I think it continues his problem. I mean, I think it's we're assuming that there is more to this than evidence-based or guideline-based treatment of recurrent acute pain, and clearly there is. I mean, if this guy has been getting ongoing renal colic, he needs help beyond analgesia. But there's a lot of indications that he's got a problem with opiate dependence of some degree, and that's just going to reinforce it for him. It's going to, it's not providing him with a different opportunity.
And isn't, as doctors, our duty to first do no harm?
Yes.
And safety, I think, is a really key issue. I mean, we know that the rate of prescriptions for morphine and Oxycontin and other prescription opiates has been rising massively. And if you look, say, for example, at the States, there's more people dying of overdose from prescription opiates than there is from heroin. They're dangerous drugs, especially when used in combination with things like alcohol and sleeping tablets. And I think that has to be, you know, first and foremost one of the things that you specifically raise and talk about with the patient.
So, now, I mean, we were taught to engage in the therapeutic relationship, to actually do the best by our patients. Is there any situation here where you think this guy would ever come back, regardless of what's going to happen here? In other words, are we just talking about a situation where we're managing to get out with the least harm? Or is there a way to actually convert this into a situation where he's likely to come back? I'm not getting the impression here this guy's going to come back, even if she's been nice to him.
Yeah, look, I think it's really, every one of these consultations is going to be different. And I think that you have to give the patient the opportunity to come back. But that means to set the agenda as to who you are as a doctor and how, you know, you might be able to engage in the future. If you just simply capitulate, then you haven't actually engaged the patient, given the opportunity for the patient to engage in a different way.
And in fact, if you do capitulate, he'll be back.
He will be back.
Whereas if she goes down this line, maybe one day, next week, next month, next year, he'll think, I need to change my life.
And maybe that's the person I could see.
Yeah.
Now, we are not, we don't just have video case studies for you. We actually are going to have them in the studio for you. This is one of the reasons why we're sitting in such a relaxed format. And we have, perhaps not a real patient, but almost a real patient for you. And this patient is actually for Brendan. Brendan, Caroline has come to see you. She's waiting in the surgery for you now.
Caroline. Hi.
Hello, Doctor.
Hi, Brendan McPhillips.
Hi, Dr. Phillips.
So, Caroline, I think I have seen you in the practice.
Yes, I think I came to see you last year.
Yeah, that's right.
I think I had a flu thing or something. Look, I normally come to see Christina, but I know that she's away, so...
She is, yeah.
I just need something very simple. I just need you to give me my script for temazepam that Christina has been supplying me. That's all I need.
Okay.
I'm actually otherwise fine, so...
Okay. Caroline, can I just check how long you've been on the temazepam for?
Oh, well, it's in my notes. You can just have a look there. Just, you know, I sort of have it on and off.
I can see she's been prescribing it for you. Caroline, maybe we haven't had a consultation before, perhaps just to let you know that with a medication like temazepam, I normally like to find out just a little bit about what...
Well, you don't need to worry. I mean, it's just in my notes, you know. Please just have a read and just give me the script. I have to pick up my son from school, so I just haven't got time to go through this today. Please just give me the script. It would be fantastic.
So you're needing to leave here pretty quickly to pick him up?
Yeah, I need to leave in the next few minutes.
Okay. Caroline, I do need to ask you some questions about...
Come on, don't give me a hard time. Just give me the script. I've been seeing Christina for a long time. She gives me the script, so please just give it to me. I just need it now, please.
If you weren't picking up your son, would you have a little bit of time?
Well, no, I don't. This is unnecessary. Christine is my GP, so I just want you to do what she would normally do because she's not here. So just give me the script.
Okay, well, yeah, it would certainly be possible for the receptionist to ring the school just to ask your son to wait while
I just need the script. There's not a problem. Just give me the script. We're not ringing the school. I need to go and pick him up. I need to pick him up myself. So just give me the script, please.
Caroline, I can certainly see that you're feeling pretty angry and agitated.
You have no idea how I'm feeling, so just give me the script. I need the script. I have to sleep. It's really important that I get some sleep. My family is falling apart at the moment, and if I don't sleep, then I can't keep my family together. Okay? So please, just give it to me.
Caroline,
I have a son who is wagging school, who's 14, who lies in bed at night and cries because his father keeps pushing him, and he can't keep up to his father's expectations. I have another son who's just finished the HSC, who was the most beautiful boy, and now his father's pushed him away, and all he is angry all the time. If I don't sleep, I can't keep this
Caroline,
family together.
I can certainly see that. Caroline, this has been going on for quite some time.
It's been going on for a long time, but I just need to sleep, please.
I can certainly see that. Caroline, I think that you're dealing with a huge amount at the moment. that's just, boy, taking you to a
I
place...
don't want you, I know you're trying to help me, but I don't need this help now. What I need is just you to give me the script and I will deal it with myself later.
Thank you very much to you both. Thanks, Brendan. You were obviously feeling it there, Brendan.
I was feeling it, Norman. Boy.
We were all feeling it.
So self-mark yourself before we...
I actually thought I did pretty well too.
You were verbalising a bit more than I thought. You know, you were giving the whoa and the oh. You were actually quite responsive there.
I think I was actually trying to buy myself time,
Right.
just to see what was happening. And I was, I think, trying not to be too reactive because I was pushed against the wall.
What would you have done if she'd said, bugger off, I'm going?
I probably would have not done anything, but have felt a lot of shame that I had mucked it up, that I hadn't actually handled it in the way that I should have. I don't think I would have tried to hold her back.
And I think we've answered this question before from the University of Queensland. The question, would you have ever asked somebody to leave if it was just getting too hot to handle and just broken up the consultation, or, you know, once you're in there, you're committed to the bitter end?
Knowing myself, I'm there to the bitter end.
Difficult though, Tim, if it's your partner who's been treating this patient and clearly not correctly, and you've got that overlay as well as having to deal with the consultation.
Well, it certainly creates a more difficult dynamic where that's right, and the patient is able to say, well, your partner, the other doctor in the practice, has said that you would do this, or usually does that, and it makes it difficult, perhaps, then to adopt a position of wanting to explore more what's going on before responding one way or the other to the patient's request. But in fact, I think that what happened there demonstrated one possibility, which is that we don't know what's been going on between this patient and her doctor and why she's been getting the scripts up till now, but we've just learned that this patient has serious problems in her family that she presumably is not getting help with, and for which the temazepam are perhaps providing a bit of a band-aid, but are certainly not helping that family move forwards.
Yeah. And certainly, Mark, who's the actor, clearly created an opportunity, Narelle, for you to intervene. You could see that there was a point there where we could actually do something.
Yeah, I mean, and I think that was the very good thing about that consultation, is that he actually got that opportunity to see what the real problem was. And I think similarly to that previous consultation, this is now a doctor who might be demonstrating a possibility to help this patient in the future, even if it's not today.
Comment from... Sorry, go on, Marion.
I was just going to say, playing devil's advocate, though, given if she's already, from what we understand, got a therapeutic relationship with somebody else in the practice, I think much more in that scenario than the first one we saw, there's perhaps a role, depending on how long the other person is away for, to say, well, I don't know, but to say something like, there's an awful lot of stuff going on. It's more than the temazepam. I'm happy to do this as a tide over until she's back, but I really feel there's an awful lot more that, you could do with some help with. Look, it might not be me, it might be Christina, it might be somebody else, but I'm aware there's a lot more going on.
Would you actually say you're going to talk to Christina about it, to the patient?
Yeah, I mean, I think in a joint practice, obviously, the patient's notes then I think are accessible. I don't know how joint practices work, but if they're accessible to the other, my understanding is that they'd be generally accessible to the other doctors. I mean, I think I would raise that with her before I wouldn't do that behind her back.
A comment here from Carol Cox at Mary Street Medical, who says practice policy, this is going back a little bit, but practice policy works quite well if there are other facilities nearby, such as an emergency department. It's much more difficult working in a small rural or remote surgery where the GP is also the only doctor attending the emergency department. You let yourself down as well as letting the patient down when the counter-transference gets going. That makes the doctor feel bad too about her own practice of medicine. Do you want to comment on that, Brendan?
I think that is exactly right. I think the problem about about capitulating, and this is obviously a very difficult situation.
Is it counter-transference when we're talking about from the doctor back to the patient? I mean,
well, I think that is a term.
Ascribing feelings to the patient that may not be there is really what we're talking about.
I think perhaps what she might be referring to is in fact her own reactions, and I think the problem is that if your own reactions get out of control, then you feel shame, and I think once you are caught in shame, then it's very difficult to actually get out of it.
I think all doctors, all of us, and particularly in general practice, need to have others with whom we can talk about these situations. It may be another colleague in the practice, it may be a friend, it may be, but I think that it's incumbent on us as professionals to have one or two other people with whom we can debrief and in whom we can say, I didn't feel good about that consultation, or I didn't feel good about the fact that I did prescribe that drug, or didn't.
And maybe even very soon after the end of this consultation that you need to take a moment to actually recover, because you will be replaying this scenario in your head, and until you've dealt with that, it's very difficult to, I think, give the next patient your full attention.
So a question here from Irene again at Western Plains that says, you know, if the patient says, look, I've tried everything, you know, you go through all your responses, you know, you've got everything off pat, you know, all the interventions that you've got in your book, and the patient says, I've tried everything, what's your next step?
Well, you know, I think
There's a great doctor in the next town.
It can also be helpful, I think, for you to have a little bit of a script as well, which is an answer to all of those things. And it might be, yes, I can hear what you're saying, but I don't prescribe OxyContin to that patient, or whatever it is. And that is actually an answer to all of those scenarios.
So, Tim, is there a set of rules or just general guidelines that you can give for how to approach this sort of situation that might help to avoid getting into tiger country?
I think having thought it through beforehand, I think having, where possible, a practice policy that's with your partners. If you're in single-handed practice, develop your own policy, put it on the wall. And I've seen practices that we happen not to where I work, but there are practices that will have on the wall a clear statement about some of the prescribing boundaries.
But what I also hear is it's about listening.
Absolutely.
It's about hearing what the patients come in with.
And I think,
the ticket of entry or whatever it is, the story.
I think it's more than the ticket of entry. The ticket of entry might be, I've got pain and I want some medication for it. I think it's going beyond that. So we saw with the first videotape that the doctor, I think, opened up space in which the young man with the renal pain, as if it might have been, was able to talk about other things, and lovely reflective sort of questions that she used. The second consultation, Brendan, by refusing to acquiesce initially to that request, actually provided some space then in which, on that occasion, this patient started to tell him more about the context.
We've got two comments from New South Wales, both in fact along the same lines. Dr Abbas at the Aboriginal Medical Service in Griffith asks, what's the harm in giving tablets for a couple of days and asking the patient to come back, either to see you or see the partner? Amanda Thompson from GPET New South Wales asked the same question. Would it be reasonable to give a script, limited number of tablets, and saying come back within that time frame when there's time to talk? Is that a reasonable strategy, or is that still a cop-out in your view, Narelle?
No, I think both of those things are suggesting a way of the doctor setting a new agenda. And as long as that's what it's about setting an agenda that the doctor is in control of and feeling comfortable with, that's not the same as capitulating, which is a word we've used.
And I think it's a nice sort of, it shows the patient that you're prepared to
come part of the way.
That's right.
I think it's important to respect the patient's position. One might not necessarily always agree with it, but I think in that situation, as you say, it's an opportunity perhaps to demonstrate a bit of give and take. You've now got a new agenda to discuss.
And let's face it, benzodiazepine withdrawal is dangerous. And, you know, you may actually be placing the patient in danger if you...
or they may go elsewhere in which case you don't have the opportunity to have that discussion. So.
And about picking your time, and if all of that's going on for her, and you know she's got a kid that's just finished the HSC and someone else that's, you know, if somebody is going to make a concerted attempt that's likely to have some hope of success, it doesn't sound like right then is going to be the time to start that, and recognising and as you say, respecting that.
Another question here from Shahid Abbas, Dr. Abbas again. Is it fair to give regular scripts to chronic pain patients who've been assessed by a pain rehabilitation specialist? Brendan?
I don't know if I'm qualified enough to answer that, Norman.
So they say, I've been to see Dr. Cousins at Royal North Shore. He says it's fine. Why are you holding back, Professor Usherwood?
Well, it's still me that has to write the script. It's not Michael Cousins. And so I guess that, I mean, we're now at the very tough end of this whole situation. I think the patient who has chronic pain, there's been a growth of the use of opioids in chronic pain management over the last decade or so. The evidence base for it is still a bit questionable.
In non-cancer pain, absolutely.
In non-cancer pain.
And you're still not sure that they actually have been to see the pain specialist?
Well, that, you might know that. I mean, you might have had a letter from the pain specialist. But even in that sort of situation, you know, I mean, I still understand that it is ultimately my responsibility what happens with that prescription and the results of it. And I think these are difficult situations. I think an important thing is to stay in touch with other treating doctors, to work with other primary healthcare professionals, allied health and others, if that's helpful for the patient, and always to be reconsidering, re-examining, are we doing the right thing for this person, this patient?
Our second film case study is Mary. And she frequently comes to see her general practitioner. She's 45 years old and has a very strong history of breast cancer and is anxious about her health and well-being. Here's the story.
Okay, see you later. Bye. So, how have you been? How's work?
Oh, you know, retail management, it's never just a walk in the park.
Yeah.
We've got a couple of trade shows coming up. They're keeping me quite busy.
It sounds pretty busy.
Yes, it is, and can be a bit stressful.
Yeah, well, here you are again. I see that it's been 3 weeks since you were last here. What have you come to see me about this time?
Well, it is concerning what I came to see you about before. If you remember, I had a bit of a thickening in the breast, and I just felt that maybe you could have taken me a bit more seriously and ordered a mammogram, because I'm very worried about it.
Correct me if I'm wrong, but wasn't it only 4 months since your last mammogram?
For nearly 5 now, yes.
Mary, I can honestly say that I cannot recommend another mammogram at this time.
But that was a while ago, and there's obviously something going on. I just feel that you didn't give me your full attention.
Every time you've come in here, I've examined your breasts, and there has been no change in that time.
Well, obviously, I can't deny that you examined me, because you did. But you were not taking it seriously.
Mary, it's my job to take you seriously. You cannot have a mammogram every couple of weeks. It's not good for your health.
Not saying that I should have.
The fact of the matter is you've had more mammograms than is recommended for most people, even given your background.
Well, I'm relieved that you remember that I am high risk. I mean, I am the same age as my mum was when she was diagnosed. I lost my mum and my grandmother to it. My sister's had a couple of lumps.
Mary, I know that you're in a high-risk group, but every time I've examined you and every mammogram has shown no change in what you perceive as being a thickening in your breast. Your sister's lumps were benign. Now, I understand that you'd be very concerned given your family history, but there is no indication of breast cancer in this case.
I've been doing some research.
What research would that be?
I've read a lot of books and I've found some information on the internet, and really there are a number of considerations.
Mary, reading a book or looking up something on Wikipedia does not make you a qualified doctor.
Well, it seems to me that my doctor doesn't want to help me, so I'm getting my information where I can. And I've been getting these headaches and these pains in my arm.
OK, these headaches and pains in your arm, are they recent?
Yes, in the last week or so, since I last saw you.
A headache and a pain in the arm does not mean you have breast cancer.
But they're all symptoms of something. We can't just dismiss
I'm not
this.
trying.
And I'm sure that
I'm happy to examine your breast again, that's fine. But there's no hardening in your breast. There is no change in your breast. Every few weeks, you come in here and we go through the same thing. I give you an exam, you ask for a mammogram, but there's no indication, there's no change.
It's nearly 5 months. That's quite some time. And there's obviously something going on.
Mary, I understand that you've had these worries for a long time. I know that your family situation's stressful. You've got 2 kids and a pretty high-powered, stressful job. But when you start getting headaches and a pain in your arm, and in my opinion, you're overly concerned with your breast cancer risk, then I think it's time to talk about a referral to a psychologist. We have one attached to the practice.
So you're saying I'm mental? That it's all in my head? That I made it up?
No, I'm saying that a lot of what's happening to you is related to stress. The stress of your job, the stress of what happened to your mum, your grandmother, what happened to your sister. And it's all funneling down to you feeling that all these symptoms have something to do with breast cancer. Now, the best way to deal with that would be to talk to a psychologist, somebody trained to deal with a stress-related disorder, which this is.
I can feel them. They're physical.
Look, trust me, stress-related problems often present as physical symptoms. I know they're real. Your headaches are real, and the pain in your arm, that's obviously real. But stress and anxiety disorders need to be treated by an expert in that area.
You seem to think it's in my head. Are you trying to get rid of me?
The fact of the matter is, you have a psychological disorder which needs to be treated.
Well, that was going to go on for a while. Difficult one. I mean, she's obviously got a real concern, which is based on fact. I mean, this is not in her head.
Look, absolutely, she's got very reasonable concerns she's come to see the doctor about. I mean, she perhaps she's obviously consulting a great deal about this, which suggests that to some extent her agenda, her concerns are not being met. You also wonder if she's under a lot of stress in her family or her job, whether she's perhaps more aware of changes in her body than perhaps we all, in fact, have a tendency to perhaps become more aware of physical changes if we're feeling under stress, and perhaps that leads to the behaviour of consulting more often. But the issue here is that she's worried about her breast and he's worried about the consulting behaviour, except he doesn't put it like that. He relabels it, I think, as her stress. So they're having conversations that are going nowhere near each other. Again, I think he needs to take time to step back and listen to the patient and try to understand the context of her behaviour and her concerns in a lot more detail.
But what might be going on in the back of his head is that you get this woman onto a test merry-go-round and there's no end to it. Biopsies, ultrasounds, MRI scans, and in fact each time you do it, you're increasing the risk that something unnecessary is being diagnosed and unnecessary investigation. So it's a hard balancing act. So it's like the temazepam story in some ways.
That's true. I think he makes a very real point that, you know, endless mammograms is not going to be helpful to anybody. But also I think he's exhibiting that sense that, you know, doctors feel most comfortable when the patient is accepting of what they say and agree with what they say. And this patient is saying, well, no, actually, I want more from you. And that is a little bit less comfortable.
He's also
for
not
us.
helping himself by being quite disparaging of some of what the patient says, which I'm sure is not helping her over. Well, I was reinforcing her sense that he's actually not taking her concerns seriously.
I think that's right, Tim. And I think his body language, he was actually pointing at her with his hand, almost as if to say, you must believe what I'm saying, which I think was having the opposite effect to what he wanted, which was to believe him. I think it was just putting her behind a brick wall.
So what's the posture he should have adopted if he was more conscious of what he was doing?
I think to, in fact, be an open posture, to allow her material to come in, and to, I think probably to just have his hands open.
And actually, she made offers to him. She said, I've been looking stuff up on the internet.
Yes.
I've been reading books.
Yes.
He could have said, oh, tell me what you found.
I think that's exactly right. Yes.
Yeah.
And also just what is it that I can do that will make you feel better today, or what is it that you know you want me to do today that will help? I think he had an idea that I just need to tell you you don't have breast cancer and you don't seem to accept it, so I'll say it again and again and again, and that was clearly a classic mismatch.
So this is the feeling that, this is the omnipotent feeling that you can get as a doctor, is that I have all the answers. And I've got to deliver all the answers here, when in fact the answers may be before you in the patient and you're not listening to.
And they're not the answer to the question
he's
she's actually asking.
attending to his frustration rather than to attending to what her distress is. That's right.
And I think it's interesting that he keeps battering at her, but I think she keeps battering at him by turning up week after week.
It's good sport.
Clearly.
Comment from Paul Campbell, a psychologist in Perth, who says this sounds like a psychological stress fear issue. Well, you would, Paul. You're a psychologist. But no, but thank you. No, I'm serious. Thank you for the comment. The trouble is dissecting it when there is a real biological reason here for her to be concerned, and there's also all this overlay, and it may well just be, as Paul says, psychological stress. But you've got to find your way through.
I think part of the interest of general practice, but also the challenge of general practice, is that we never deal just with physical problems. I noticed that one of your, somebody's written, in surgery seems like a pleasant specialty.
This is Darryl D'Souza who's written it.
Well, actually, each to their own. But for me, the fun and interest and satisfaction of general practice is that whilst we do deal with biomedical, pathological disease, we also deal with behaviour, with stress, with thoughts and feelings, and we try to work with the patient at the intersection of these issues.
And that's why drug and alcohol medicine specifically is so interesting. And that's, you know, they're often typically a patient that, you know, people would say, oh, you know, the last thing I want is someone with drug and alcohol issues. But for all those same reasons, that's what makes it so interesting and potentially so rewarding.
So, I mean, Darryl D'Souza was making your point as a joke there, that surgery seems like a great specialty. But in fact, you could actually imagine that that's what happens to this woman. You could think of a scenario where she gets fed up with her doctor, she goes doctor shopping, and she'll eventually find somebody who says, well, if it's such a bother and you're so concerned and there's clearly such a strong genetic thing, why don't we just do a bilateral mastectomy on you?
But I think the problem is, the issue perhaps is that sometimes doctors feel like the answer to all problems is to do something, to actually do something. Whereas in this case, just having the patient come and talk about that distress is often enough, and that's all you have to do, but you have to give the patient permission and time to do that, which might mean scheduling some regular appointments, not doing something.
In other words, give them space, and he doesn't give her space.
Yeah.
She doesn't have the space to talk about what's going on.
Yeah.
So do you believe in the concept of somatizers?
Yes, I do. But I'm not sure it's happening here.
No.
I think
It's dangerous to think that it's happening here.
Yeah, I think she is just so frustrated that she's not been understood. He's so frustrated that he's not been understood. They've polarised again, and there's not much space in between. And I think actually it is up to the doctor, because there is a power differential in this situation. It is up to the doctor to take a step back, have a think about what's not working, and then try something different.
And of course the risk here is actually the opposite from what we've seen, which is that he's worried that he actually is missing something. He's going to get sued if he's missing something. He really believes there's a psychological issue here and he needs to get through that, but he's going to do more and more tests because he doesn't want to miss anything either. So everybody's on a merry-go-round.
I'm not sure that's happening there. I mean, I was surprised.
Well, it's not happening there,
no,
but
it could do. There are situations
sides,
where that's right, and you worry that the patient who keeps coming back and worrying about a disorder may have a disorder and may well refer them for a biopsy.
And Paul Campbell, our psychologist in Tasmania, has come back to us saying, I feel this is very much a power relationship rather than a partnership, which is what you were saying there.
Well, I think it's a power struggle.
It's a power struggle, yeah.
Let's look at another way that our GP might have dealt with this situation.
Yes, but the last time I saw you was 3 weeks ago, and I'm telling you that there's something there and that you should have a proper look.
Okay, you're saying that I didn't examine you properly last time.
No, I acknowledge that you examined me, But I didn't think you were really concerned about why I was there, and I felt that you didn't have my best interests at heart.
Okay, I think this is something maybe we should tackle directly, because I've had a feeling that there's been something not working between us for quite some time. Okay? As I understand it, you feel that I'm not taking your concerns seriously. Maybe I've been fobbing you off, or a little bit removed and maybe a bit abrupt.
Definitely, especially when you consider my history and my family's history. I'm 45, the same age as my mum was when she was diagnosed, and I really think you should take my concerns a bit more seriously.
And the results of the examinations and the mammograms, they're not helping you feel reassured?
Yes, that's right.
Look, I understand that you're concerned that you'll be diagnosed with breast cancer. You're at the same age your mother was when she was first diagnosed, and she died soon after, is that right? This is bound to be a very scary time for you. Cancer is a very scary word. It's a very real fear, especially for you, given your background. You're going to be more vigilant than most women because of that. Look, it's very reasonable that you're going to have these concerns, and I guess it doesn't help that you feel that I've been quite dismissive of your concerns.
No, it doesn't. It makes me feel better knowing that you understand that. It's hard when everybody says you're making it up, as my husband said to me the other night.
A lot of women find that it's easier to talk to a woman doctor about these sorts of things.
Another doctor?
Oh, Mary, look, we've known each other for quite some time, and if it's okay with you, I'm quite happy to continue being your GP. But it's something to keep in mind. Do you know Dr. Matthews?
Mm-hmm.
Well, it might help to talk to her at some point, maybe over a couple of appointments. But for now, I'd like to get together a plan of action that will agree with both of us.
What did you have in mind?
Well, we'll keep up with the mammograms. For somebody your age, it's generally recommended once every 2 years. But considering your history and your level of concern, let's make the next one in 12 months and see how we go.
Well, that's going to be quite hard for me. The mammograms actually reassure me.
Yeah, that's right, but the reassurance doesn't really last very long. So what I would like to do is work out a schedule of breast examinations so you're here every couple of months. How does that sound for you?
Well, I guess that would be okay if you were okay with me coming in that regularly. I might need to come in more often sometimes.
Yeah, that might be, but let's deal with that when it happens. In the meantime, let's see how we go with the schedule.
Marianne, what do you think?
Look, I think he did obviously a lot better in that consultation. I think there was more of an understanding that there is an issue about risk of breast cancer, very real, significant positive family history, and an appropriate medical approach to that. But at the same time, there's the issue of your distress, that the results are not bringing you the sense of relief or peace that you're looking for, and this is another separate issue that we need to deal with in a different way.
Narelle?
Yes, I agree. I think clearly it was a much more comfortable consultation for both of them.
So he's doing basically what we've suggested,
Yeah.
which is listen, acknowledge, capture, move on.
Yeah.
In a sympathetic way. And
I think, though, that towards the end, he started to get a bit controlling again.
Yeah.
He decided how often the frequency of the mammograms were. He decided the frequency of the consults. And she sort of resisted slightly. She said, "Oh, I might need to come more often." But I thought, having acknowledged her distress, having very bravely, I think, acknowledging the dysfunctionality of the relationship, he perhaps then could have given her a bit more space and say, let's try to establish a plan for monitoring your breast health. What would work for you?
Which I think is exactly right, because the thing, as I sense it, is that she's just she's terrified. She's at the same age that her mother was when she got the cancer and died.
Yeah.
So I think for her, the experiences have been out of control, and I think that's exactly right, to actually give her something.
Yeah.
And this business of offering his partner up?
Yeah, I was interested
That's
in
the
that.
kiss-off, isn't it?
I personally didn't feel it was perhaps done as well as could have been. Like, I think, you know, he was wanting to to create an environment where perhaps she felt okay about asking for someone if she wanted someone else, but that I don't think was what she wanted, and perhaps in a way he's done it. In fact, the message he's given is, I don't want you anymore. So I think there would be a different way of bringing that up and offering it, rather than, you know, do you want to see someone else?
I think that's right, Marion, especially as it was so close to when the relationship actually had gone off the rails, and here he is suggesting that she goes off and sees someone else in the same consultation.
It's getting a bit like the wide world of sport, the between ball analysis, but let's continue on with some more of our live action today on Wide World of the Rural Health Education Foundation. And Jan is, sorry, it's Marianne is our next victim. Marianne, Jan.
That's the right word, I think.
Jan is waiting for you in your surgery.
It's a busy surgery day, but no, welcome. See you. Hello, Jan. How are you?
Marianne.
It's really nice to see you again.
Lovely to see you as well.
It's been a little while now, I think, isn't it?
Yeah, it has been, and I'm actually not here for myself today. I'm fine. I'm actually here to talk about Sarah. You know, she's just, I don't know what to do. She's, you know, she had her 18th birthday about 2 months ago, and probably about a month or so before that, she just became really withdrawn. She stays in her room most of the time at night. She's not interacting with her family at all, and I really don't know what to do. And I know that she's been to see you a couple of times, so.
And what happens when you try and speak to her? Has there been any communication, or is that
not
shut
a
down
lot?
completely?
It's, you know, pretty just basic interaction. Like, she'll answer me, but we don't get involved in conversations. When I've tried to ask her what the problem is, she just doesn't tell me. So I know that she's seen you. Well, I don't know, and I know that she's seen you, and I just thought if you could just let me know what's happening with her, then, you know, I can try and help her and try and manage things. Yeah.
Look, I would love to be able to. If you're asking for information that I may have about her,
she has seen you, and if you can tell me what's happening with her, that'd be fabulous. And you know, then I can work out what to do, because I just don't know quite what to do.
Look, it sounds like a really difficult situation, and firstly, I think. You know, the love and care that you have for your daughter that brings you here today, you know, I wish that I could say that for all of the patients that I have at my practice. In terms of the logistics of me giving you information, there's actually privacy laws that stop me doing that. A bit the same way you might hear of you know, a lawyer, for example, can't speak about particular confidentiality
but she's my daughter, you know. I mean,
I know.
You've been a family GP since she was,
for a long time, since she was...
Exactly. Yeah. I mean, come on, you know. I mean, you're part of the family. I just need to know what's happening, and then I can help her, you know. I'm just worried that it's actually getting worse, and if I don't do something about her situation, then I don't know what's going to happen.
And look, I think you must be going through an extremely difficult, you know, situation at the moment. I can only imagine. It's tough enough being a mum at the best of times, let alone watching someone that you care for.
So you need to help me. You're our doctor.
Yeah, and I will do absolutely everything I can, Jan.
Yeah.
That will involve all sorts of things, but what it can't involve is the specifics of any interaction that I may have had with your daughter.
But I don't think you're understanding. She's locking herself in a room at night. She's talking to herself. You know, she goes around with her head hung down. She stayed out last night for about 4 or 5 hours, and she didn't tell me where she went. You know, so I don't think you actually quite understand, Marianne, that I actually need this information, and you know, it's not going to go any further than me. I'm her mother, for God's sake.
Yeah, I know.
You've got to help me.
Have you spoken to anyone else, or is what else is going on in her life? Is she still getting to school at all, or?
Well, yeah. I mean, she's just finished school for the year, but you know, I mean, you're the one who needs to help me in this situation. You need to tell me what's happening for her.
Yeah, and I again would reiterate that I will do everything I possibly can to support you and to support your family. As you say, I have been the GP for your family for a long time. I can only imagine how difficult this situation is.
So you're not going to help me, are you? Basically, is what you're saying.
I will do everything I can, what I
So you're not going to tell me what's wrong with her. So are you happy to take responsibility if she, you know, in 2 weeks' time does something terrible to herself, if she harms herself? Are you happy to take that responsibility?
I think as a doctor for any of the patients in the practice, their safety is absolutely my concern, and I can assure you that is always the thing that's uppermost in my mind. I really appreciate how hard this must be for you.
I don't think you do, actually. I seriously don't think you do.
Thank you very much. Well, they were certainly getting to all your vulnerable spots, Marianne.
Yeah, look, and you know, I mean, I think that the thing about that consultation is, you know, heaven knows, your heart goes out to this person, because you can only imagine what they're going through, and while you want to at some level reassure them, and there might be some reassurance that would go with the line, "It's okay, I'm seeing her, she'll be okay." There's issues as to whether or not you can say that.
And it's a bit like the breast cancer story, because parents of children or adolescents with serious mental illness are terrified, and they also they often lack confidence that the clinician actually understands what's going on, and they think they know what the situation is, the clinician doesn't, and there's no point of contact, and therefore people's mental health suffers because of this confidentiality issue.
And I think that's probably something that it would have been better, you know, reflecting, you know, to get that information from her. There's stuff that she would have that, you know, if you were the doctor of the daughter as well, you would want to know from her point of view what she was perhaps saying. But again, it's that fine line of who is my patient at the moment, and who am I actually trying to help at this point.
So is it legitimate, Narelle, to capture that information and say you're going to intervene with the daughter? Because then you've just got all this multiple confidentialities running here.
Yeah, no, look, it's really difficult, and I think you've got to be really upfront about who knows what, and, you know, does the daughter know that she's come today, and, you know, all of those things have got to be very clear.
Yep. I think it's useful to bear in your own minds two facts, really. One is that the law says that you can't breach confidentiality for an adult, except under some very narrowly defined situations which don't cover this, and that's something you might well want to say to the patient. That's then something that's out there, that it's not my decision, it's a legal framework. The other thing, though, to bear in mind is that it is important for everybody to feel safe, that they have a safe, confidential space to talk to their doctor. So in fact, from the doctor's point of view, it is important to remember that this daughter does need that confidential space that she can talk to Marianne, and that the moment Marianne breaches that confidentiality in any way with any family member, then the patient no longer has her confidential
And of course
space.
you can express that to the mother.
So you can express that as well.
But I think, Marianne, you identified something crucial, which is that you have been pulled apart in two directions. So one direction was that you actually wanted to help her, to help this mother, but also your allegiance to the daughter as well. And I think the experience of being pulled in two directions at the same time, in a way both of them are right, leaves you in an incredibly difficult situation, which, I mean, I don't think there is an easy answer to it.
Let's go to our last live action for this evening, who is Sharon Brendan, another one of your patients. And we're going to get you into this situation where it's the end of the consultation, you've written out a script and it's just coming to an end. Go and meet Sharon.
So, Sharon.
Thank you.
Here's the script.
Thanks for that, that's great.
Okay, well, it's very nice to meet you.
Yes, you too.
I'm new in town, so...
Yeah. I just, I meant to say it at the beginning, but I want to welcome you to the town because
great. Thanks, Sharon.
We've been wanting a GP for a long time, so it's really nice that you've been able to come here.
Boy,
it's
you know, it's, I moved from Sydney up here and it's beautiful. It's
so
a lovely town.
It must be a big thing for you to come,
it's huge.
You know, leave
it's huge.
your hometown. And,
but I'm very happy to be here.
Well, it's really lovely that you're here, really nice.
Great, thanks, Sharon.
Now, I hope you don't think I'm being a little bit forward, but I'm having a barbecue on the weekend. I just live about 5 k's out of town.
Right. Okay.
And just a few friends are coming over, so I thought it might be an opportunity for you to perhaps come along and meet some people.
To meet some people?
Yeah.
I think that might be quite nice.
Okay,
Thanks,
that'd be
Sharon.
lovely.
Okay.
Yeah, they're just there's myself and my son living out there, and we're just having a few of the local people coming out, people sort of our age. So.
Okay, good.
Are you married, Brendan?
Am I married?
Yes. Obviously not, if you can't remember. I mean, if you have anybody you'd like to bring, please feel free.
Okay, thanks, Sharon.
Otherwise,
I probably won't. But
okay, all right. Well, it is a long way out of town, so
okay.
You know, there's some space if you need to stay the night, and you know, if you want to have a few drinks, it's
I think we've got the message on this one somehow. Thank you, Brendan. And I'd like to thank Marg, who's been our actor this evening, who's done a fantastic job. So, Brendan, you were getting a bit close to the line there, I thought.
Well, I think I was ambushed.
Tim, who's the other bloke on the panel?
Well, I mean, seduction is a possibility in a consultation, and it's not necessarily heterosexual, so and it may be in either direction. So, I mean, it seems to me, yes, that Brendan was ambushed, that he was, that Marg was being. I think one has to respect that. I mean, it's her decision if she wants to negotiate a possible new relationship, and there's a new man in town. But
the line is the line.
But I mean, the person though who's responsible for maintaining that line, and has an absolute responsibility for maintaining that line, is the doctor. So let's not blame the patient, and let's acknowledge that it's the doctor's job. Now, the doctor was ambushed. I mean, it was initially a very social invitation, but it clearly starts to get more limits, or higher expectations than one could imagine where it would go. The doctor's job is to identify that that's happening and to work out what they're going to do about it.
Difficult in a country town, though, Narelle, when there's only a limited number of people, a limited number of opportunities, and situations can arise which are entirely innocent, and knowing how to negotiate them, you can potentially become socially isolated.
Look, I think it's a very difficult issue to negotiate in rural situations for all of the reasons that you've said, and I don't think there's any easy way around it, really.
So let's just talk about crossing this line for a moment, and what the strategy is when it's even perhaps more overt than that, or you are feeling an attraction towards the patient. You just have to assume that can happen at times, and just how you deal with that, what strategies you use without wanting to, and you are the only doctor in town, and just how you manage that process, because the line is the line, you cannot cross it.
I think throwing in that the doctor also might be having needs themselves, and might also be lonely. So I think it probably would be a good idea for the doctor to reflect him or herself on their situation, to see what...
So this is the mentoring that Tim talked about earlier. There's somebody you can go and talk to about situations which occur.
Absolutely. Just
so that you can unload and debrief.
Absolutely. I think the work that we do is, I think as Tim said, it's got enormous rewards, but I think you also often go to an edge as well. And I think if you're having to try and manage all those things by yourself, I think you can get into a mess.
But you can't allow yourself to come close to that line.
I think sometimes you find yourself at that line whether you like it or not. And I think when you're there, as much as possible, to try and give yourself space, to try and give the person space, and to, I think, as much as you can, avoid shaming the patient, and also avoid shaming yourself. And I think in this situation in particular, to capitulate is actually very dangerous for everyone.
Because I think there's a sense that the doctor also needs to feel safe inside the consultation as well, and that needs to be a safe place for the doctor as well as the patient. And I think elements have been introduced here that are probably making that doctor feel quite unsafe.
And if the doctor doesn't, sooner rather than later, do something to ensure that the appropriate boundaries are restated and re-established, it's ultimately not going to be a safe space for the patient either.
Exactly.
If he's the only doctor in town, if they start a relationship, if the relationship finishes, then where does she go? Quite apart from the fact that he's, you know, hopefully will be up in front of the medical board, and rightly so. But it actually, and the reason for these strict rules is not about keeping doctors safe, although I agree you need to feel safe in the consult. It's actually about providing safety and ongoing care for patients.
I think one of the problems is that I think the rules are absolutely crucial, but I think one of the things that can happen is that, like, because we're human beings, we do sometimes find ourselves in situations where our quite fragile, primitive emotions get triggered. And one of the things that I think is crucial for us is to actually know ourselves as much as we can know ourselves.
And that's where colleagues, friends come in.
Yes, and I actually think that, Marianne, you sort of mentioned about drug and alcohol patients perhaps being the bane of some GPs' lives, but in fact that you find it...
the delight of mine.
That they're a delight of your life. Because I think one of the things that difficult consultations do is that they're difficult and they take us to an edge. But I think we actually find out things about ourselves that we wouldn't otherwise know.
And we've got a couple of final questions coming through on the web, but knowing yourself and knowing that in that situation the answer is thank you but no, and being quite firm and mature about that.
Can I just make a comment about that, Norman? I think that one of the things that I have been surprised about over the years is that when I actually do say no and do set limits with people, it's often quite a surprising reaction, that rather than become enraged, which sometimes they do, but I think sometimes people are actually craving to have limits, especially people, you know, who have very fragmented personalities. And I think it can sometimes actually be a great service to them, just to say, this is it, no further.
Question from a general practitioner in Canberra: how do you deal with a patient with a personality disorder causing chaos in the waiting room?
With difficulty, depending on what they're doing. And again, I haven't worked in a typical sort
borderline
of
tray, acting out. I'm the only important person in the waiting room. Why am I not being seen? Noisy, belligerent.
And a lot of that depends, I guess, on the practicalities of the practice, and you know, is there another physical space that they can go? Is there anyone else that's available to kind of take them aside? You know, how well are they known? And you know, obviously they're going to have particular issues on that day that need dealing with, often with people with personality disorders. If there's ongoing issues, although obviously things, you know, wax and wane depending on what's going on in their life, but putting in place some kind of a plan in terms of, you know, when they come and times and...
Tim, just changing the subject, we've had a question about how the overlay of being Indigenous, you know, so if you're working in an Aboriginal medical service, and there are all sorts of cultural issues which add a layer of complexity sometimes to a consultation. What's the approach here?
I think that, I mean, I've worked in urban Indigenous health now for 15 years, and I continue to learn. It's a wonderful environment as a non-Indigenous person, as a POM in fact, to continually learn new things about this ancient culture. But I think that as a doctor working in that context, it seemed to me that I need to understand that Indigenous people have a very different epidemiology of disease. They have a very different pattern of illness prevalence and incidence and prevalence. They also have obviously a very different historical and cultural background to many non-Indigenous Australians, let alone blow-ins like myself. So one needs to understand that context, but then one has a responsibility to encounter the individual person as a patient with their own needs, with their own story, and not to stereotype them in terms of any of that background knowledge.
A question from Jenny Caitlin, who's studying to be a diabetes educator, who talks about trying to get families to engage with their care. One family declined to participate as they're praying to God for a cure. What suggestions do you have here? So, I mean, this is the story where people, you have evidence-based care, you know it's going to save their life. It might not be diabetes, it might be something else, and they say, no, I'm off for the mung beans or the rolfing. You can get stuffed with your orthodox medicine.
In the end, all you can do is offer people options. You can give them a lot of information about those options, but in the end, people have the right to make their own decision, as long as you have provided all the information that you can. I don't know what else the answer is to that question.
And maybe finding someone else that can provide some of that information that may be a person in the community, whatever that position they hold, where that information might, for whatever reason, be more accessible to them than coming from you, perhaps.
Yes. A question that we had at the beginning that's been asked again by a general practitioner in New South Wales, in remote New South Wales: is it legitimate ever to end a relationship with a patient because it's so difficult? And how do you do it well? Who wants to pick up that one?
I think it depends on the nature of the relationship. I think we've seen some difficult relationships here that have, in fact, been changed, I'm almost going to say transformed, when the doctor has been willing to, or has decided to listen further, to try to develop a broader understanding of the patient and of the reason for them coming to see that doctor. So I think there's often room for moving forwards, and sometimes it takes years to get to that position. I think there are relationships where one has got to seriously think about ending them. One is where there are where the patient is acting out in a threatening or violent sort of way. I think that needs to be stated clearly to them. They perhaps need to be given clear advice about what the consequences will be of ongoing aggressive or violent behaviour. But if that continues, then there needs to be a sanction of ending that relationship.
I think the answer also is yes. One of the things that I think I've learned over the years is that there are some patients who I actually can't deal with, who I can't see because of what happens in me and because of what happens in the interaction, that it actually just isn't helpful for them. And I guess coming back to knowing yourself, I think there are some people who we actually shouldn't see, and respectfully just to move them on to someone else.
What do you take home messages?
Overall, I guess for me it's about being honest in the situation, honest with yourself about what you're able to do, what you're not able to do, honest with the patient about what you can and can't do, and if there is some big elephant on the table that needs to be addressed that you're all skirting around, talk about it.
Tim?
Listen to the patient and then listen to some more. Really try to understand why the patient's there, why they've come today, what the problems are that have brought them today, what else is going on in their lives, why they've come to see you in particular. Yes, I think that's the main thing.
Narelle?
Well, look, I think we all have a comfort or a discomfort meter. I think that it's good to become attuned to that because it tells you something about something that's happening in a consultation that you need to attend to or change. So listening to yourself, I think, is a very important thing.
Brendan?
I think difficult consultations are difficult consultations. So I think when you encounter one, which undoubtedly you will, to take a deep breath, realise that everyone has these experiences, be kind to yourself, and talk to colleagues.
And the last word from one of you at home, Alison Edwards, who writes, "Good session, thanks, though it has felt a little like a really bad day at work."
Really bad day.
Oh.
You should have
We were trying to be so entertaining. But thank
It'd
you,
be
Alison.
nice if we could get the opportunity to rerun consultations.
That's right. I hope you've got a lot from this programme on ways of managing difficult consultations. We must thank the New South Wales Health Department for making the programme possible, the Pam McLean Centre, and all of our featured actors who were so generous with their time, and thanks also to you for taking the time to attend and contribute so richly, even you, Alison. Thank you very much indeed. If you're interested in obtaining more information about the issues raised in the programme, there are, as always, a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms and to register for CPD points. I'm Norman Swan. See you next time.